Hello, everyone. My name is Lydia. I'm the clinical care coordinator at Children's National in Washington, D.C. And our team has been focused on bringing early screening type 1 diabetes screening, into the day-to-day rhythm of our clinical flow, ensuring that it's accessible, sustainable, and meaningful for our families. Today, I'm going to walk through how we've designed and implemented a workflow to identify at-risk patients early, support our families through education, and create a consistent process for follow-up and treatment discussions. Let's see, I'm going to do it on here. There we go. Perfect. Our objectives, we'll quickly review the importance of early screening and staging. I'll outline the implementation of our two-pronged approach that consisted of education and workflow coordination. I'll review key outcomes from our first year of screening, and then lastly, identify next steps to continue our efforts. So why early screening matters. I'm not necessarily going to spend a whole bunch of time on the scientific reasons for why early screening matters, because I think that this room is well aware of the importance of early detection and staging, as well as recognizes the potential to change the trajectory of type 1 diabetes care. But what I do want to spend time talking about is what's always mattered the most to our team. And it's not necessarily been about giving our patients and families a test result. It's so much more about giving them time. So giving them time to understand what the results might mean, time to prepare emotionally, practically, time to learn about emerging options for monitoring intervention, and really just time to make a well-informed decision for their child and for their family. As we know, screening opens the door for education and support long before a crisis point. It helps families feel empowered instead of blindsided, and it also helps us build trust and a shared understanding from the inception of care. This philosophy of pairing clinical systems with meaningful patient engagement has always and continues to be the foundation for our approach to this implementation. So when we went to look at what we were working with, we did not necessarily have a whole lot going on. So we had no standardized process for identifying eligible patients. Our ordering was inconsistent. Our education varied by staff member, and many families were just completely unaware that screening was even an option. And so, of course, as a result, eligible patients were missed and our follow-up was fragmented. So when we sat down to design our goal, we chose not to focus just on increasing screening numbers, but to build a sustainable system. So one that connected education, workflows, and EMR tools to make early identification part of our normal clinic operations. Our project aim was then to establish a systematic antibody screening process to identify and monitor patients at risk for type 1 diabetes. We identified 4 main drivers: patient and family awareness, provider and staff engagement, and sustained workflows and policies that were supported by integrated EMR infrastructure. These drivers really gave us our roadmap, and from there, our work naturally evolved into 2 main focus areas, and that being education and the workflow coordination. Education addressed awareness and engagement, while workflow coordination ensured screening was built into the fabric of our clinic operations. On the education side, we developed clear, accessible materials explaining early stage type 1 diabetes and the purpose of antibody screening. We translated those into Spanish and Amharic, embedded those into our clinic touch points, such as our new AdSent binder, our triage area, et cetera, and we reinforced those in our educator and provider discussions. In parallel, we also hosted cross-disciplinary sessions to keep our providers, educators, admin staff, et cetera, informed and invested in the shared effort. On the workflow side, we created a structured process for both ordering and follow-up, and that meant EMR-based order sets, tracking tools, standardized follow-up sets for positive results. We defined exactly who does what, so who is ordering the screen, who's reviewing the results, and who's communicating next steps to our families. And this structure really helped make early screening more consistent and more sustainable across all of our providers. Since the start of this effort, we've screened 61 patients. Of those, 28 were antibody positive, 10 were stage 1, 11 were stage 2, 9 of which were eligible for Tzield. 5 of those patients ultimately received Tzield, and 1 unfortunately progressed to stage 3. The rest of our patients remain under active monitoring. Although our numbers may seem small, they are mighty. This first phase of our work was focused on building a reliable system and workflows. So the real outcome was consistency. Screening that is now happening intentionally instead of incidentally. Our families are hearing about early screening and detection in clinic conversations. They're learning about what it means, and in some cases, they're assessing interventions that they might not have otherwise known about or thought were possible. So we still have much to learn, but have learned a good amount so far that we wanted to share. First of those being that champions drive change. So identifying a dedicated leader has really helped sustain momentum and accountability. We've also learned that patient-centered care is essential, and really just that each family's experience for readiness for screening is unique, and really just meeting them exactly where they're at. Education is foundational, so consistent and accessible information has empowered both families and staff. When folks understand why they're doing, why it matters, their engagement and follow-through improve. Equity requires intention, so tailoring our education and our communication through translation and expanded outreach were essential, not optional. Small changes really have created a big impact. So something as small as a standardized order set of a couple of labs has reduced variability and simplified the process, which in turn is increasing provider follow-through and use. And then finally, EMR-based workflows have reduced missed opportunities. So embedding those screening orders and the follow-up prompts directly into our EMR has shifted it from being a reminder-based process, which hinges on our providers, and instead just being a built-in automatic one. So as we look to the future and look for our next steps, we can hope to continue formalizing what we call our T1 delay clinic. And this is our structured pathway for antibody-positive patients to receive consistent follow-up and education and when appropriate treatment discussions. We're also expanding our multidisciplinary team to include psychology and nutrition into those early screening appointments so they can have that support there. Right from the get-go. Also hope to continue developing automated dashboards for ongoing data tracking. And finally, expanding our outreach to other specialty clinics. We've also partnered with our GI friends to screen celiac patients and look to do so with other specialty clinics, as well as going out into the community so we can reach more families upstream. With all of these efforts and our continued partnership with folks like yourselves, we hope to continue making early screening more than a test, but a chance to change the experience of diagnosis for our patients and our families. And with that, I thank you very much.
Hey, thank you, Lydia. I'll open the floor to questions.
Hi, my name is Isabella. I'm from Seattle Children's, and I also don't directly do the screening work, but I was curious for your T1 delay clinic, how often are you seeing them back, and what is the follow-up usually like? I'm sorry, I'm looking.
I'm hiding amongst the crowd. Yes, no. Great question. So our T1 delay clinic right now is a bit ad hoc and very much personalized to the patients. For our patients who are identified as being stage 2, of course, we've got a really tailored follow-up system for them. For folks who it's maybe stage 1 or it's even like pre-stage, we'll put them into the routine 3-month follow-up or 6-month.
Any other questions? I know you had a question earlier. Did you still want to ask?
It was a comment actually rather than question. So Unable Bioscience, I used that for a long period of time. When I hear that free, I just feel like it's not completely free, but if that's true, let me know. I can talk to them why it's not free to us. But it's a free if it's covered by insurance, but if it's not, they say that it will charge them like about $50 or $70, something like that.
So I just met with them last week and they said that they're doing it's free no matter what. That's what they told me in Chicago. I don't know. Because they said that they're just collecting insurance, but even if you don't have insurance, she assured me that it was at no cost right now. That could change, but right now I can put you in touch with her.
That's good to hear. So thanks.
I apologize if I missed this at the beginning, but when you're reaching out to like catch your screening, did you talk at all about, are you guys also trying to screen like your celiac patients or your Hashimoto's or that sort of stuff as well?
Thank you. Yes. So we just started this partnership with our GI folks, and they are right now just focusing on their celiac patients. They have a celiac clinic that they are targeting. And then, yes, it's very much our next step to talk to our endocrinologist friends who are in our team, just to, expand that outreach as well. Yeah. And our GI, I'll say too, our GI friends, they were really willing and super excited and eager. So it was just as simple as starting the conversation and answering their questions and spending some time with them. So it's been great.
So you mentioned that you are moving towards a more proactive model of screening rather than a reminder-based system. Can you expand a little bit more on how that looks like when somebody's checking into the clinic and how you're identifying people who need to be screened?
Thank you. Wonderful question. And I love too, I've been gathering some ideas. I love the pairing the sibling appointment. So I think we're going to do some chart review. But one thing that we are really excited to get started on is actually putting myself more into clinic. So again, doing some chart review of patients who are coming in. And essentially, I will swoop in right after the appointment and say, hey, my name's Lydia. We're going to talk about early screening. Creating those touch points there as well, just to meet them right there while they're in the clinic. But we have to figure out the exact mechanisms of that. I'm thinking, again, chart review. I also love the idea of a newsletter. We've been wanting to do that for a really long time. The letters as well. I think that that's great. So yeah, looking forward to it.
Also, can you say your name, your clinic affiliation as well for those on Zoom? Thank you.
I am Ginny Swang from UCSF Pediatrics. For those of you who, I guess all of the speakers who had implemented in clinics, I guess the bigger question is how, I know you talked a lot about provider buy-in and really getting it integrated. Overall, and maybe it's a hard question to answer, like in all of the priorities that there are in clinics, how you've worked with leadership, how you've worked with both leadership and folks in your clinic who are doing the work to try to prioritize this, because I think this is a common struggle. It's like, well, we can barely get our current patients in, and this, again, when you look at the numbers, smaller, right? So how do you make that argument that this is important? And that goes for any of you.
Yeah, I'm curious. I'll pass the microphone so we can also chat with you guys too. We are very lucky in that our director of diabetes services is the one who's spearheading this effort. So that was easy to get that buy-in, but definitely a challenge. One of the big things that we focused on is the champion. So we have we have 3 providers who are our kind of go-tos and are really involved in this process, but definitely a struggle to get everyone involved.
Yeah, it's a great question. I would say that is our biggest struggle. We are more so focusing our efforts in the type 1 visits. So really targeting those families most. And then, the hypothyroid patients, sometimes they're quicker visits. So we kind of talk to our colleagues about saying 1 or 2 lines about quick, options to screen in a brief, 2-minute little spiel. And then if they say yes, then we can always do a telemedicine visit follow-up, talking more about the screening if families have more questions.
I'm the director of the diabetes program in my center. So I spearheaded this. I was the champion. We were lucky to get 2 new, 1 PA and 1 nurse practitioner. At the time we were talking about this, and they did not have a lot of things to do. So I said, you guys are going to do screening. So we were really lucky. And as our center started seeing money come in from TZL, they have been very supportive. So we got really lucky that way.
Thank you very much for all the great talks. I'm Marina Bassino from Stanford Adult, and I guess I have a question to all of you. Have you implemented or discussed with your adult colleagues whether the parents or adult siblings of the children are getting screened as well, because I have a number of families that were parents diagnosed later in life, and they're even 70s when they have kids, when they were diagnosed as kids.
Okay, so our adult clinics are struggling with screening and Tzield, and we've invited their family members to come to our site and get tested via TrialNet, but they have not figured it out. I think they're still trying to figure it out.
I was going to say at Riley Children's, we are fortunate right now that we have one of our TrialNet research team members coming into clinic and popping in after visits and asking about screening and monitoring, not just for the kids, but for the adults. And so that's been how we've been capturing more of adults, but also working with our adult colleagues to maybe get somebody who's a champion for early stage in the adult world.
We also have not really had too much partnership with the adult colleagues, and we're kind of focusing first on the pediatric and then hopefully expand.
Yeah, same with us. Sorry, I don't have any, but I love that idea. We have all sorts of QI projects going on, and transition clinic is a big thing that we're working on. So I love, maybe we're going to incorporate that in the discussion. Thank you.
Hi there. My name is Haley. I'm from Cincinnati Children's Hospital. And it's kind of a comment, but also a question. A lot of you have mentioned different strategies to getting these patients screened. And my question is, like, who is that right person to bring it up, and where is the right place to do it? Because I love the sibling combination. It makes sense. It's hard to get a patient to an appointment, but then that appointment could go longer, and then the burden is on that provider. But that provider has seen that child, hopefully consistently with continuity, and they have a relationship with that family. And then I also think PCPs really do have a place here, and like involving them in this. And, once again, like bringing it up with the family at a well child visit, like your child is healthy, but we know this is out there. So just thinking about other ways to get people in the door and get them screened, because I think there's multiple players that could be involved in this whole process.
Mark Moyet with SUNY Upstate. So we're a little lucky. I'm the outside, but we are one floor. One side of the floor is pediatric, the other side of the floor is adult endocrinology. Getting patients in for screening is a little as a challenge for the adult side. What we're trying to do is to involve the primary care physicians more, where we essentially educate, and there's also these flyers that are available online that you can educate the primary care physicians, tell the patients to ask their primary care physicians for a set of tests, and that usually is quite successful.
Yeah, I agree. And I think we all probably agree of the PCPs definitely play a really big role in there. And I think that, bringing it up in the well child visit makes the most sense, or at least just mentioning that it's an option. I think the struggle, of course, is ensuring that the PCPs feel comfortable. I think that that's been our discussions with them. They don't feel like they know enough in order to answer all the questions. And, we try and reassure we're here to answer all the questions, and like let's partner and refer. But it's still, I don't know if we just still have like a ways to go. So we haven't quite figured that out, but yeah, it's definitely an opportunity there.
Yeah, I've talked with a lot of different PCPs. I think some feel more comfortable than others. And then kind of going with the barrier discussion too, some PCPs feel like they have so much to cover at the well child visit that they don't have time to kind of bring this up. But we're trying to encourage them and trying to talk to them about quickly, talking to the families. We're going out maybe and giving some education as well to the PCPs so they feel more comfortable. And like I said, we created an order set that they can use that can be helpful.
But what seems to work is if the patient walks in and says, I want this.
Yeah.
Primary care physicians oftentimes lower burden would be just to give in and do it, as opposed to have a discussion why they don't want to do it.
I was just going to comment that there's almost too many options for screening, which also provides a layer of confusion for primary care physicians on where to send individuals to screen. If your institution does, initial provider visits through telehealth or something to talk about screening, I think Texas Children's is doing that, and that seems like a really great setup. But I know at Riley, like we just don't have the bandwidth to have somebody dedicated to offering a telehealth visit just to discuss screening options. So I think everybody's resources are different and how you do that.
One thing I want to mention that we haven't yet got started on yet, but we're really excited to. We have Children's National also serves the DC Public Schools nursing staff. So we have a really great partnership with the schools. And we have 2 folks on our staff who are really invested in this work and partnership with schools. And we're going to start introducing the conversation there as well. And trying to, again, we've just started, so we aren't sure how we're going to start getting the word out, but if it's engaging the school nurses, if it's including it in some sort of binder that goes home with kids or on bulletin boards or something of the sort, so that, because totally agree, I think that having patients and families go into the PCP visit and say, hey, I've heard about this, I want to learn a little bit more, what can I do about it, would be great. So we're excited to get started on that.
I have Patty Henley from New Orleans, Delaware. One question and then 2 comments. The first comment is I think we still get a lot of pushback from providers in clinic with the only option being Tzield. I know everyone's excited about Tzield. It's the only thing we have, but the 14-day infusion, all the barriers. As there are more stage 2 trials, so 26, there's going to be a JAK kinase inhibitor. And I think we're at the breaking point where we're going to see more and more. I don't think Tzield is going to be it. I think you'll also get more buy-in from your endocrine providers, because a lot of people, when we started to do a pilot, was, well, what options do we have besides that? And knowing that those are there is an option. The other comment is, I think, on antibody screening and all the options causing confusion and the differences in validity in the test. And I think it's something that as a group is worth it exploring in the future. So whether you're doing ECL at Barbara Davis or whether you're doing ELISA with Quest or LabCorp, they are different. And I have patients that have had positives at LabCorp, normal on TrialNet, and normal on Barbara Davis. So, those kind of things just as a bigger group. Right now, obviously, the goal is just to get the screening done, but I think that's something that will be a big effort in the future. And then the last thing is a question. So you guys, meaning DC Children's, about 50% of the people you screened were positive for antibodies and about 10% got Tzield. I know it was 5 out of 61. So what was different about your cohort as opposed to just luck compared to Chicago, where I don't remember from the beginning of your presentation, but seeing that, I mean, more than almost half of your patients had positive antibodies. So was there something specific, or obviously just luck of the draw maybe over time, but about who you screened? Because if we all did that screening, we'd be really happy with those results.
Yeah, thank you for that question. I think, again, our this first phase of our effort was, focused on just making it really consistent. And so our cohort of kids that were coming in from referrals, so hadn't yet necessarily really broadened our screening effort. So I think now, with these next steps that we're going to be taking, are really curious to see just kind of, the range of kids that we'll see. I don't know.
Okay, we got a question from Zoom. For those that are partnering with GI and rheumatology or screening with autoimmune hypothyroidism, where are you getting the autoantibody testing done if there's no family history of T1D? Are you charging insurance? And is there payer coverage for it?
We've been sending it to Quest, LabCorp, or our children's lab. I have not heard of any insurance issues so far.
We have as well. We also send them either to Lurie or Quest or LabCorp as well. And we've had no pushback. I've had no pushback as well from any financial concerns.